Anak kepada Tricia Chemaka, a 6-day-old baby boy born via SVD at 38 weeks and 4 days with birth weight of 3.08 kg at the 10 to 50th centile. His circumference 33 cm and height of 47 cm. G6PD is normal, caught TSH of 5.13 and caught pH of 7.34 with mother's blood group of A positive. So for this patient's birth history, so baby was born with a weak cry, born with an APGAR of 9 in 1 minute and 10 in 5 minutes. And actually baby, because of the weak cry, was given free flow of oxygen for 5 minutes. Subsequently, the baby was not tachypnic and had a good cry, and then they off the free flow of oxygen. Subsequently noted by staff nurse in the labour room that the patient became tachypnic with a respiratory rate of 70 breaths per minute. Then
initially not tachypnic.
Initially not.
Then
Initially was just weak cry.
Noted tachypnea at how many hours?
At maybe less than 1 hour of life.
Okay.
Yeah. So then that time the respiratory rate was 70 breaths. But then upon attending by the doctor at that time, doctor noted not in respiratory distress or tachypnea, but then the RR was 45 breaths per minute. Then they still gave the free flow of oxygen, and then the SpO2 was 98% and heart rate of 131 beats per minute. They trialed off the nasal prong at that time because they put the baby on nasal prong, and then had intermittent tachypnea with respiratory rate of 50 to 60. They also did a reflostat at that time, was 2.1 millimoles per liter, and then they gave feeding, and then reflo post feed was 3.5.
The reflow at how many hours?
Also at the same time, so less than 1 hour of life. Yeah.
Okay.
And then immediately after feed, but child had no symptoms of hypoglycemia at that time. Then immediately post feed reflow was 3.5. Otherwise, for antenatal risk from the mother's history, she's actually known to be a GBS positive mom, covered with IV benzylpenicillin 2 doses right before delivery. She has underlying beta thalassemia carrier, but no family history or no previous screening done, no previous blood transfusion history. And also mom has maternal obesity, but no GDM, no preeclampsia, no other antenatal risk for this mother. Social history wise, she's a Nigerian lady, stays in Malaysia, used to be a student at Present College, but now just works as a hairstylist. Yeah, married, and then husband also stays in Malaysia. Yeah.
Okay. So, what happened after that?
Then subsequently, patient was transferred to our ward, and then after that, we continued nasal prong oxygen for 3 days, and we also started.
So the admission, what do you think the cause of the rapid breathing?
What is the cause of the rapid breathing? Because it was immediately after delivery, so it could be possible transient tachypnea of newborn. It could also be because mom is a GPS positive, so maybe a presumed sepsis, maybe an early onset neonatal sepsis. Maybe an underlying cause that would have caused.
What else GBS can cause other than sepsis?
Meningitis.
Can. Specifically causing tachypnea?
It's causing tachypnea. Respiratory distress syndrome. But usually it's more common in preterm.
No, for GBS related, what lung problem can they have?
Pneumonia. So can have congenital pneumonia.
Okay.
Yeah, so possibly a congenital pneumonia as well.
So you say TTN, what is the history that suggestive this one may be TTN?
Term infant, right after delivery, and then.
But the mode of delivery?
SVD.
So SVD can have TTN?
Unlikely.
A bit less likely, right?
Yeah.
I wouldn't say cannot lah, but a bit less likely.
Less likely, yeah.
Why?
Because TTN happens when the child cannot resorb the lung fluid. So it's usually in like a Caesar or like emergency or elective Caesar when before term or right at term they deliver.
Okay. So why SVD don't pose a risk for TTN?
Don't pose a risk.
Why Caesar only?
Maybe the SVD when you deliver the child immediately cries, and then
there's nothing to do with the crying. It's something to do with the delivery process itself. What about the delivery process? What is the difference between the emergency cesarean and SVD?
Usually emergency Caesar, there is no like
No what?
it's like induced, right? Like we
No.
are the one that's causing
So
delivery.
in TTN, what basically flooded the lung?
The amniotic fluid.
Okay,
Yeah. So in SVD usually there'll be rupture of membranes prior to delivery, but then
okay.
in Caesar there is still amniotic fluid right before delivery.
That's not the reason per se, but you're
Okay.
getting there. So if you say rupture membrane, the fluid come out, but the one that come out is the one in the uterus lah. But the fluids in the lung still not out yet.
Yeah.
Can you see? So why in TTN happen in cesarean, why not in SVDs? We still not answering the reason why.
TTN happen in Caesar and not SVD.
Think about the delivery itself.
Mm.
What is the difference between SVD and cesarean? In cesarean, baby come out where?
From the abdomen.
Yeah. Okay. So in SVD?
From the pelvis.
Okay.
Vagina
So
cavity.
you think which one is narrower?
Oh, the SVD
Yeah.
vaginal cavity.
So when it's narrow, what happened to the lung?
When it's narrow, the lung is compressed. Squeezed.
Yeah. So they squeeze what out?
They squeeze the whatever fluid that is inside the
Yes.
lungs. Okay.
Understand?
Yeah.
Okay.
Yeah,
So
so-
that's why it's less likely for SVD to have TTN lah.
Okay.
So can you, it's like a sponge, you squeeze it
Yeah.
out. So you less fluids, less likely for TTN to happen lah. That don't really happen in
In
cesarean.
yeah.
Cesarean, yeah, if they have difficulty to bring out the baby, even through the cesarean scars, cesarean section, they usually use forceps and all that lah. Catch the head and deliver lah. But the squeezing thingy don't really happen during the cesarean delivery lah. That's why they pose risk for TTN lah. Okay. Alright. So if you say it can happen, you say TTN. So usually TTN resolved by how many hours of life? Well, by what day of life they should have resolved?
By day 1, day 2 of life?
Up to
5 days.
too much lah tu.
Okay.
So up to
3 days.
up to 3 days lah, up to 72 hours. If still after 72 hours they still taking milk, so what you must think about?
Congenital pneumonia.
I can
or
think of
RDS.
something else lah.
Yeah, respiratory distressing.
Okay, so if you see in terms of clinical natural progression of TTN compared to RDS, what is the difference?
Usually RDS is quite bad. The child will be quite sick, and then they'll have chest recessions, constantly respiratory distress. So like chest recession, and then we need to give like high flow of oxygen for the child. So probably the patient will be on some kind of oxygen support. Whereas like TTN, they are mostly we can wean off a bit more faster.
Okay, but in terms of severity, both can be severe lah. Alright, but the natural progression of RDS is they probably okay in the beginning, but they progressively getting worse by the time progress. I mean day 1 they okay, by towards the end of day 1, day 2, you see the acute night getting worse and worse. Most of the time RDS is like that lah. Whatever the severe one from the get-go lah. Alright, so TTN usually should resolve by 72 hours lah. So RDS, the treatment is for what? With what?
We can give surfactant. So we give surfactant to ETT tube. Patient is intubated.
So how does surfactant helps?
Basically, the surfactant acts to mature the alveoli.
Does it act to mature the alveoli?
It produces more alveoli space.
No, that's not the reason.
It
That's not.
increases the surface area of the.
It doesn't increase the surface areas. What does it do exactly?
Increase the lung compliance.
Yes, so by reducing the lung, the surface what?
Surface tension
Of
the alveoli.
yes.
Okay.
So it doesn't do anything to increase the
Increase
alveoli
the-
number.
okay.
It just reduce the surface tension lah.
Tension.
So when surface tension reduce, the lungs more compliance. Alveoli more compliance. So it can distend, can expand for the gases exchange to happen. Okay, so it doesn't reduce, doesn't increase your alveoli, doesn't increase the maturity, nothing. That one is just from the gestation lah. Over time, the lung will grow in numbers lah. The alveoli. How many stages of lung
Contribution.
lung maturation?
I think 4.
So
But
what do
I'm
you
not
know?
sure which one.
Okay, so lung maturation happens until at what age? So alveoli happen at how many weeks of
Life.
the formation?
The formation from I think 34 weeks onwards.
Okay, so the lung maturation ultimately bila? Until at what age? Lung fully matured?
1 year.
No, cannot be 1 year. Until how old?
1 month of life.
No.
Less than few.
Way.
Less than a few
Way
days.
older.
Oh, older.
Ah.
6 months.
No, way older. Super older.
Oh, like adult like that.
Almost adult one.
Like 10, 11.
Like teenagers.
Teenagers.
Lung fully matured at
18.
teenagers.
Okay.
So that's why even BPD and all that, they still have chances to get better over time lah, because the new alveoli formation completely matured at teenagers of age. Okay. Alright. So that's why most of the time, so complication of this prematurity to the lung over time is what?
Complication of prematurity lung. They can get bronchopulmonary dysplasia. They can get frequent pneumonia. They can have frequent lung
Alright.
infection.
So in terms of BPD, if the severe one, usually they go home with what?
At home CPAP.
CPAP atau
Or BiPAP.
Or other than NIV, they go home with
Oxygen.
yes, oxygen only.
Yeah.
Sometimes it's just oxygen, sometimes it's CPAP or BiPAP lah. Because I think CPAP and BiPAP, they probably have concurrent airway issue. If you don't have airway issue, just lung issue, they only need oxygen. So most of the time, if they go back with CPAP, BiPAP or oxygen, usually by what age they can off the BiPAP, CPAP? Roughly, just estimate.
Teenagers.
No lah, it's not until that age lah.
Maybe a year.
Yeah, roughly 1 year, 2 years, 3 years. Most of the time they can off oxygen or CPAP already lah, because of the lung growing. Okay, but that does not mean the lung is normal. So there are a lot of scar tissue. Understand?
Yeah.
So that's why they can have acute exacerbation of chronic lung lah, because this scar tissue can cause easily get probably spasm, something like that. Okay. Alright. So other than this BPD, RDS, pneumonia, TTN, what else? Are few other causes of respiratory distress in newborn?
Neonatal sepsis.
Can some? So you already mentioned TTN, congenital pneumonia, RDS, sepsis. Some more? And then the 2 or 3 more. So you have to basically, when this patient come in, you have to determine what is what, so you can manage accordingly, because different diagnosis, different management. So another 2 or 3, these 2 or 3 is still quite common. So when you go for standby, I know you all don't go for standby per se. So what information you want to know?
I want to know the maternal history.
Yes, other than gestation, other than maternal history. What else you want to know?
I want to know if antenatally the scan got any issues with the baby.
Alright. Okay.
Maybe they have congenital diaphragmatic hernia also can cause.
Yes, that's another reason.
Yeah.
That's another cause. What else? Ada 1 more or 2 more?
Persistent pulmonary hypertension newborn. So
Yes,
they have a cardiac problem causing.
Not necessarily have to have cardiac problem,
okay.
but PPHN is always secondary cause of something.
Okay.
1 more?
Maybe an underlying congenital heart disease.
They don't really come in respiratory distress. They just blue. Okay. 1 more. When you go for standby, what you want to know in terms of the during intrapartum itself?
Intrapartum.
You done ONG already?
No, I haven't.
No yet. You go for ONG, right? When they worry when they do patient got rupture membrane or they do rupture membrane.
Bleeding usually.
What you want to know in terms of
The liqua
what about the
volume,
liqua?
the liqua color, any false swelling liqua.
So what about the color?
Color if it's meconium stain.
So what-
meconium aspiration syndrome.
Yes. Okay. So MAS as well. So how do you differentiate the MAS and
And
congenital pneumonia?
MAS usually the and like during delivery intrapartum baby will start having fetal like bradycardia, and then after that liqua won't be clear, and be meconium stain, and then
So if you examine the baby with meconium stain like what can you see on the baby?
meconium
Huh.
meconium liqua around the baby.
Okay, but where can you examine for that meconium stain on the baby?
Much.
Where will the meconium stain the baby?
Aspiration, so probably the
Okay, the lungs one, some more. Lung airway, alright.
Airway.
What else? What else you stain? Anything that can be stained?
the fingers.
What the finger exactly? Where exactly?
The nails.
The nails. Some more? Apa lagi yang putih on the baby? What else is white color on the baby? No, the skin lah. Skin is chocolate brown.
White color.
Ah.
The eyes.
I not really. That one only for jaundice. What else on the baby attached to the stomach?
The umbilical.
Yes.
Umbilical cord.
You can see the stain over there lah, especially the thick meconium, which for sure the umbilical cord will stain, and your nail as well. So on the X-rays, what do you see compared to pneumonia and MAS?
I'm not too sure.
Not sure. So think about pneumonia and bronchopneumonia, like
They say perihilar haziness.
not say perihilar, if
But consolidation.
consolidation lah.
Consolidation.
Alright, probably localized.
Localized.
Okay, but compared to meconium and
Because
MS,
aspiration probably it's like fully hazy, or like
not sensory fully hazy. So
or
meconium,
episis only is more.
think about meconium. Meconium come in small size, form, and big, multiple shape and size. So what can you see on there?
So it's small consolidation.
I wouldn't say small consolidation. It's just multiple.
Multiple.
Okay, and then multiple small in size. I wouldn't say like honey.
Honey cluster.
No. It's not like that. Like you just see we say haziness everywhere with small rounded shape everywhere like that lah. So depend on where the meconium attach. Most of that is quite generalized. Okay, rather than pneumonia was one side consolidated. Okay, in TTN, just X-ray.
In TTN can see the air fluid, the
Air fluid?
line. Sorry, the
What
fluid
line?
level line.
What is it called?
I forgot the name, but it's a line.
Where? Left side, right side.
Right,
Why right side?
because the diaphragm.
No, how many lobes on the right lung?
3,
In left lung?
2.
So
More lobes. So
the horizontal line tu is
Horizontal.
which in between what lobe?
second and third.
Yes, middle and lower lobe.
Middle.
So fluid in the fissure. That's the fissure.
Yes.
Okay. RDS. What
RDS
changes?
is white out lung, so it's like.
Why is the term? Seems like COVID.
What?
Why you describe the chest X-ray or COVID patient and RDS patient same description? What is GGO? GGO. COVID is always short from GGO.
I remember white out lung, but then
There is specific term for it. What is it called?
I'm not sure the specific.
Something glass.
Ground glass opacity.
Ground glass lah. Okay, the ground glass they have at least 3 to 4 grades. Grade 1, grade 2, grade 3, grade 4 lah. Okay, even for RDS. Okay, TTN dah, RDS dah, pneumonia dah, MAS dah. Okay. So PPHN, as I said, is always secondary. What is the primary thing usually causing PPHN?
Can be a congenital heart defect.
No,
No.
it's all the other causes lah. It's always secondary to something. TTN can cause PPHN.
Oh, okay.
MAS for sure can cause PPHN. RDS also can cause PPHN. Pneumonia also can cause PPHN if you don't
Treat properly.
treat the first one. Even TTN, if you leave the child huffing and puffing, taking milk for so long, then so if you see the child breathing like that, what are basically the signs that will like basically give you a clue, suggest to you that this baby might need intubation?
So if the patient is in respiratory distress, so chest recession, nasal flaring, respiratory grunting, cyanosis, tachypnea, tachycardia.
Okay.
So yeah, that would probably do.
Okay. So before you intubate, usually what do we give? We try to escape intubation.
We give CPAP first, so positive airway pressure, and then we see if the patient is responding, and then
how do they give the CPAP?
the neopuff.
Yes, neopuff. Neopuff, what is the proper term? Don't know.
Not sure.
So you have your bagging, right? The bag too. So what kind of bagging do you know? The types, the normal one. Adult use, we use.
Yeah.
What is it called?
Back valve mask.
Yes, back valve mask lah. And dia punya popular term is what? What is the name of the brand?
Oh, the brand.
I know it's back valve
Sure.
mask. Embu bag.
Embu bag.
Yeah, I'm sure you know.
Yeah.
Embu bag. Everybody call it Embu bag.
Yeah,
Embu bag.
Embu
Embu bag. Okay, so Embu bag comes in small, multiple size. But problem with Embu bag, they don't give.
It's not a positive airway pressure.
Yeah, they give positive for PPV, but it don't provide constant PEEP. What is PEEP?
Positive expiratory and
Terbalik. Positive.
Positive and expiratory pressure.
Okay. So what does it do?
So basically, we can inhale and exhale. So with positive airway, it's like it's like forcing the lungs to like take in the oxygen that we're giving.
Taking the oxygen.
Like it forces to open the lungs.
Yeah, so they keep the airway open. During
when the child cannot breathe.
What is the name of the PEP just now? During what? During which phase? Inspiration or expiration?
During inspiration.
What is the PEP stand for?
During expiration, sorry. Positive and expiratory pressure. Yeah.
So in the normal lung, does the airway collapse?
No, normal lung don't collapse.
So what happened in the child? What caused the lung to collapse?
The lungs probably got the fluid, so the
so
alveoli
TTNs, the
collapse.
portofiscal is filled.
Fluid, yeah.
In
Filled.
MS?
In probably meconium filled the alveoli.
Okay, so MS there are few basically mechanisms lah. Okay, one is your
Meconium.
meconium. When meconium is stuck in the airway, so what does it act?
Where does it act?
What does it do to the lung when it's stuck to the airway?
Obstruction.
So it acts as a one way
valve.
Yeah, so air can go in
but cannot come
go
out.
out. So what happens to the alveoli over time?
Alveoli will get too expanded.
So if you too expanded, what happen?
It start collapsing.
No, it doesn't collapse. Kalau become more expanded, what happen?
Burst.
So burst, what you call it?
Alveoli.
Then like if it got burst, lung bocor, what happen?
Oh, perforation.
No, what you call? Not perforation. So the air escapes into
the pleural cavity.
So what you call it? Kena masuk something apa? What you call it?
Pneumothorax.
Yes. Okay. Alright, pneumothorax. Okay. So that's why MAS can cause pneumothorax. Okay, that's one. But probably don't. Yeah, sometimes it probably start as air cannot go in at all. And we collapse as well. Okay. That's another thing. Then meconium is chemical thing. So what happen when you have chemical tissue? How the tissue will react?
It'll start breaking down.
cause inflammation.
Inflammation.
So the inflammation of the lung called what?
Inflammation in the lung.
What's the term?
Pleural effusion.
No. Pneumonia is infection of the lung.
Infection of the lung.
So pneumo what? Inflammation that indicate inflammation.
Pneumonitis.
Yes, pneumonitis. Okay, so you have inflammatory going on also pneumonitis lah. So there are a few reasons why they keep taking it in MS. Okay, next. In RDS, you know already lah what happened?
RDS causing.
Why the lung collapse?
Oh, because the underlying not enough affected, so the alveoli is not much collapse.
One more apa? What is it? Sepsis lah. Okay, fine. So airway collapse because of all these reasons lah. Okay, so your PEP keep the
airway open.
Alright, so keep airway open so that patient next breathing will be airway doesn't collapse. So your breathing will be
regulated. Like
easier to
manage oxygen.
Easier to inflate
the lung.
If airway collapse, so that's why they use their own
accessory muscles,
because they generate their own to overcome that.
They generate their own pressure to overcome the end expiratory that they cannot.
So that's why they baby grunting. Why baby grunting? How does they generate the grunting?
The glottis is like partially closed.
Yes,
so they have to like use their own effort.
So why they have
to
to partially close the epiglottis to create that what?
To create the positive pressure.
Yes, to PEP lah. So it's all this physiological thing only. Okay. So but problem is if you let them create that physiology,
then
use their muscles,
and then eventually they cannot breathe.
Okay, so initially the problem is what type of respiratory failure?
First will be type 1.
Then
becomes
become tired.
Type 2 because hypercapnia in type 2 because they cannot release the carbon dioxide.
Alright. Okay.